Good morning on this beautiful Berlin winter day. Thank you for coming early, and thank you to the organizers for giving us the opportunity to share some ideas on the issue of corruption and the health system. My name is Kobus de Swart. I have the privilege to be the Managing Director of Transparency International. We have an esteemed panel. I will introduce them as they are about to speak. So I won't do long introductions now, but do it when they speak. Very simply, I will make a few opening comments. We will then have panel presentations. And at the end, I hope to have about 20 to 25 minutes for brief questions and for the panel a chance to respond. Corruption negatively impacts health services and outcomes in many ways. These include embezzlement of public budgets and kickbacks, undermining access to and quality of care, and it erodes, very importantly, public trust in healthcare. As the World Health Organization have clearly indicated, corruption also leads to high levels of inefficiency, including, in many areas, significant financial wastage. Because of corruption's significant negative effect, one needs to realize that corruption has real victims, and those victims are people that, because of corruption, not only don't get the health care they need and deserve, but also that it costs lives. Very importantly, particularly at a time when we are looking at the good governance dividend of issues of transparency and integrity, better governance of health systems will also lead to much better outcomes. So it's not only about preventing corruption and its negative effects, but taking advantage of the positive benefits of good governance. One of the challenges that corruption and health are often viewed as two separate policy issues. And particularly when you look back at the Millennium Development Goals, we didn't have a good integration and a holistic approach to development, corruption, health systems. Here we now have, with the Sustainable Development Goals, a very different development paradigm, and one that inevitably is very helpful in terms of us looking at health outcomes and governance issues in a much more holistic way. Very recently, only on the 15th of September, the Secretary-General High-Level Panel on Access to Medicine released an important report with good action recommendations, but particularly underlined the value and the usefulness of governance, accountability, and transparency to our issue in terms of better health outcomes. With all of that said, I'm particularly pleased for the panel that we have, because regardless of the type of corruption in the healthcare sector, we have specialists that will talk to different elements of that this morning. We will start off with Sophie Persson, who is the Director of Transparency's International Pharmaceutical and Healthcare Program. And Sophie will share with you a few ideas in a very short presentation of about 5 minutes. The other panelists will speak longer for about 12 to 15 minutes. Sophie, the floor is yours.
Thank you very much, Kobus. Good morning, everyone. So my name is indeed Sophie Persson. I'm the Director of Transparency International's Pharmaceutical and Healthcare Program, which was set up about 2 years ago, looking at how to tackle and address the issue of corruption in the health sector. So coming to this session this morning, some of you may have asked yourselves, what does corruption have to do with health? And how does corruption constitute a significant barrier to achieving the Sustainable Development Goals and to meeting the international community's commitment of leaving no one behind? We at Transparency International define corruption as the abuse of entrusted power for private gain. This means individuals that exploit their positions of power to gain something for themselves. Arguably, it can be quite difficult to use this definition of corruption in the health sector. After all, you can claim most individuals are entrusted in some way. Officials at a drug regulatory agency are entrusted to make sure drugs are safe. A company that makes hip implants is entrusted to make high-quality implants that work. And healthcare professionals are entrusted to deliver the best quality care for their patients. So where does unethical behavior end and corruption begin? Traditionally, corruption has not been a public health concern. It's a cost that rarely gets quantified in cost-effectiveness analyses, a risk that often goes unmentioned in project appraisal reports. Yet corruption is a real barrier to achieving universal health coverage. And it can worsen health outcomes in many ways. For example, siphoning off resources that are supposed to be devoted to healthcare through embezzlement or absenteeism, increasing the cost but decreasing availability of medicines and medical devices. It can also constitute a barrier to accessing health services if you think of poorer populations who are particularly vulnerable to bribes. The bottom line is that corruption is reducing the overall availability and quality of health services. Research underpinning a report that we're releasing today, Diagnosing Corruption in Healthcare, shows that corruption has become normalized. From the politician to the patient, corruption is part of doing business in the health sector across the world. In other words, corruption is pervasive within healthcare. Now, to support this new publication, we've developed a website which is on the screen here, launched this morning, just like you, up bright and early to look at corruption in the health sector. And it is articulated around the 8 areas that we have identified as being highly vulnerable to corruption. So if I can make this work, and I can, you will see that they're outlined here. And I invite you to have a look at them later on. And if you click in one of the sections, you'll see there's a definition, there are case studies, and there's just more information so that you really get your head around what we're talking about in this work. And I really encourage you to have a look at it this morning, and later, of course. Our report shows, for instance, that healthcare professionals do not always understand what corruption is and how it can undermine their work. Conversely, anti-corruption specialists do not always understand or fully appreciate the complexity of the health sector. Our report attempts to bridge that gap by providing a guide to the health sector and the types of corruption that can occur. I would also like to invite you to have a look at a handout that was given to you this morning. It contains information about our work, as well as a case study about 500 patients who were given unnecessary cancer treatment while the prescribing doctor earned millions of dollars in false claims. Patients who only had weeks to live were given painful and unnecessary chemotherapy treatment that drastically reduced their quality of life. In many cases, you'll see some of these patients didn't actually have cancer. While there were over 500 direct victims, there were thousands of indirect victims as their families were made to suffer as well. The doctor in this case was ultimately sentenced to 45 years in prison. At the end of his trial, he admitted, "I misused my talents and permitted this sin to enter me because of power and greed." So coming back to our work at Transparency International, we're here to ask, how can we recognize corruption? And I would argue, crucially, how can we act? At Transparency International, we believe that we need a multi-stakeholder approach, which is mirrored in the panel before you this morning, to address the corrosive impact of corruption in the health sector. We need a united front, and I hope that many of you in the audience this morning will join us in this journey. Thank you very much for your attention.
Thank you very much, Sophie. Our next speaker is Dr. Agnes Kofinal, Senior Economist at the OECD, specializing in analysis of health systems and policies, and particularly looking at inefficient care and waste.
To move to the next one, this is the order, and this is the next one. Okay. Good morning. As you just heard, I'm working on fraud and corruption at the moment as part of a bigger project of the OECD. It's a background report to a meeting of OECD health ministers, which will take place in January this year. And we've been asked to look at, as the OECD Secretariat, to look at inefficient spending and waste. And one manifestation of ineffective spending and waste is obviously fraud and corruption. So this is what I'm going to tell you a little bit about this morning. I'm not going to run you through the outline. You'll discover it as we go along. The first difficulty we faced when we started this work was that there are so many terms to define, to talk about this topic, and everyone has a very specific meaning. And it has also different legal implications in different countries. So we wanted to abstract from the semantic debate, and we said we're going to be looking at what we call integrity violations, which is basically any activity that diverts resources intended for the health sector for the benefit of specific people. So this includes fraud, corruption, abuse, and many more. I think that this is a topic which is gaining attention in OECD countries. So that's why I talk about integrity violations and not fraud and corruption, because otherwise you have to say fraud, comma, corruption, comma, abuse, etc., etc. It's a bit long. So we tried to find data to assess the prevalence of corruption in OECD countries. Obviously, corruption is hard to measure. Thankfully, we have Transparency International. So there are basically two main types of measures which are used to assess the level of corruption. One is perception surveys, and one is investigation-based data. So the perception, this is from Transparency International, and we looked at global averages as well as average across OECD countries. And this is a survey in which respondents in different countries, I think it's 107 countries, are asked to tell the level of perceived corruption in their sector. As you can see, there is, particularly when it comes to public services, there is higher perception of corruption in non-OECD, on average, in the world, than in OECD countries. And I must say I was a bit surprised to find that the bars here are ranked by decreasing level of corruption in OECD countries, and you can see that the OECD, the health and medical and health sector is towards the right of there are many more institutions that are deemed corrupt in OECD countries. But still, it means that a third of citizens believe that the sector is corrupt or very corrupt. And if you look, across OECD countries, it ranks from 70% in Greece to 10% in Denmark. So even within that lower average, there is a huge, huge range. Investigation-based measurements. I just gave you two examples. I'm not going to give you the numbers, but in the Netherlands, what's interesting is that these numbers show that when you have a presumption that something is wrong, then actually proving that you have corruption is a long, it's a complicated thing to do. So from a detected 53 million of what you think might be fraudulent claim, in the end they could only prove 18 million were actually fraud. Another figure which I thought was interesting is from the US, where they have to publish a yearly report about fraud and corruption in public insurance systems. But they show that for every dollar invested in anti-corruption or fighting against fraud and abuse, they actually recover $6. So it's actually a pretty striking number, I find. There is a report which is published yearly, which tries to pull together exercises from different measuring fraud and corruption based on investigations across OECD countries. They claim to only look at exercise examples which are really sound methodologically, and on average they see that about 6% of health expenditure are lost to fraud and error. And error, this is important because, and I'll come back to this, you have to recognize that there can be some errors when you file a claim in a complicated system. Now, this is what I can say about the extent of fraud and corruption in OECD countries. Now, as we've already heard this morning, fraud and corruption are really multifaceted. And so what we did is we tried to look at all the documents, great literature examples, newspapers, articles we could find, and we put all this on the board, and we tried to organize, see where does corruption take place, and can we create categories. And we did this using an idea that was given by Bill Savidoff and other colleagues of trying to map this to people who are involved either as perpetrators or victims. So you have these 5 categories of stakeholders, and from that we identified 3 main categories of integrity violations. The first one is really in service delivery and financing. So this is false claims or trying to get insurance coverage when you're not entitled to, or denying coverage to someone who's actually entitled to it. So this is mostly things that happen between the insurers, the payers, and the providers of medical goods and services. You could call it insurance fraud, but in some countries that don't have insurance might say, well, we don't have fraud because we don't have insurance. Well, if you have payroll, if your doctors are salaried, you're actually going to have payroll fraud, and it still falls into that broad first category. The second category is integrity violations in procurement and distribution. I think it speaks for itself. And the third one is inappropriate business practices. In the context of the report that I'm working on, we're only going to talk about the first and the last category, because procurement, in a way, at the OECD we're always looking at what are countries doing to tackle various problems. And when it comes to procurement, there aren't that many health sector specific solutions. What you have is a problem of public procurement, which can be more or less prevalent in that system, but it doesn't lend itself to specific health sector policy solutions, or not that often. So when it comes to dealing with integrity violations in service financing, what we look at the report is, what we found most striking is that across OECD countries, the level of effort that goes into preventing and tackling fraud and corruption and abuse and integrity violations in financing is really varies tremendously across countries. And this starts by, it's in a way illustrated by the institutional setup. In some countries, you have dedicated units that work on this. In many countries, you have an explicit mandate given to the payers to actually look into fraud and corruption. But in other countries, what you have is there is a general anti-corruption body which is allowed to and may from time to time look into health. But it's a completely different level of investment. And the best practices, or then there is a second level of variation. It's in the level of effort that goes into actually detecting fraud and corruption. So some countries rely on investigating complaints or regular audits. But some people go further, and they have hotline where people are asked to and encouraged to report any abuse they see. And then other countries yet use statistical and data mining tools to try to understand, and bring out more information about what might be going wrong. Other countries yet, or in parallel, also do specific targeted investigation. When they see a sector is kind of looking shady, then they'll go and do an analysis of cochlear implants or home-based hospital, as was the case in 2014 in Portugal and France, respectively. The responses, so when you detect a problem, the responses must be graded, comprehensive, and credibly enforceable. It's very important to involve the providers, to gain consensus of what is wrong and what is wrong or not. Because if you have abuse, it's simply it's hard to say what you're doing is wrong. And you also have to, so you need to build consensus around this, that if you go this far, then this is a problem. A very powerful tool in that is providing benchmarking information to providers and say, look, the average people are doing this is what you're doing, and that sometimes is simply enough to prevent future occurrences. You may also set new rules because then the next time the problem comes around, then you can lie back to this and say, look, now we have a rule and this is what you should be or should not be doing. Then if you really have fraud and abuse, you might want to go into investigation, and this is complicated because you actually need people who can investigate and look into medical information, have access to information which is private. So not everybody can investigate claims, and this is something that is not always, you really need dedicated people. Some countries actually think that publishing the results of this exercise at regular intervals is really helpful because it creates a deterrent. Now, the other type of integrity violation I'm going to talk about, the other main category, is inappropriate business practices. And again, this is a very multifaceted problem, and capturing its essence is very difficult because what you have is lists of cases of corruption, and you don't want to be naming, that company or that hospital, etc. So we try to find an abstract way of talking about it. I think when inappropriate business practices is when you're trying to ultimately what you want to influence is the patient who's going to be asking the treatment, the prescriber, the regulator, because the regulator is in charge of the safety, of assuring the safety of the population, the payer, because if you convince a payer that what you're doing is right, then it might get covered, and of course if it's covered, there's going to be more demand for your product. So these are the ultimate target of these inappropriate business practices. But you can also have a set of intermediary targets, which are the people who convince these ultimate targets. So patients' association, research institutions, opinion leaders, etc. And these are the main categories of levers you can use and misuse, and I'm not saying they're being misused all the time, but so direct funding, financial incentives, persuasion, and so on. Another issue we found is that there's a very unbalanced way of talking about this. I mean, you'll have some people say big pharma is bad, and then you have innovation is good, and that's basically where the dialogue stops. And I think it's important to have a balanced view of this, and there are many legitimate business objectives that any business, any entrepreneur in the health sector can pursue. And an entrepreneur is not necessarily a pharmaceutical company. It can be a GP, a general practice. It can be a hospital. It could be an insurance company. So we're looking at this quite broadly. And so what a legitimate, constitutes a series of legitimate business objectives is promoting a business-friendly environment. You want the regulator to understand what you have to do and the constraints. Now, what becomes a problem is when you shift to institutional corruption. You want to gain market entry if you're a business because it's regulated because to protect, the entry into the health sector is always regulated to protect safety. So you want to gain market entry, and where things can go wrong is either if you try to use inappropriate ways of, you exert undue influence on the regulator to gain entry, so you bribe the inspector who visited your facility and says it's up to standards when it's not. But you can actually also present information to the regulator that will distort their decision-making process. And so this is, you can think of, not presenting or selectively presenting information on clinical trials. And this is all about gaining market entry. And then you can try to increase the demand for your product once you're in the market, either by manipulating the demand, and these are some of the examples that we were looking at, Sophie was talking about. Manipulate the demand, and then also try to convince people individually to do your things, so inappropriate detailing, for instance. How is that tackled in OECD countries? The short answer is that we mostly rely on self-regulation, codes of conduct for the industry, and conflict of interest policies for physicians, researchers, academic institutions. I think the main question we have about this is that these efforts, or the impact, so the adherence is generally voluntary, and the impact and compliance are not systematically measured. I think that increasingly there's regulation which is emerging in country, more and more regulation, and in different domains. Unfortunately, regulation is often in a given country prompted by scandal. So there is a scandal, therefore there will be a regulatory response after some time. And these are the different types of regulations that we've seen emerge over time. But even if there is a regulation, quality of enforcement remains a concern. Thank you very much.
Thank you very much, Agnes. I think two things that stand out for me. One is the value for money of preventative work, the 1 to 6, compared to the difficulty of investigations afterwards. And then the issue that Agnes highlighted, I think, is very specific to the sector, the lack of a consensus about what needs to be done amongst providers that we find in other sectors to be less of an handicap than here. Our next speaker is Andrew Daniels from GlaxoSmithKline, where he heads the Anti-Bribery and Corruption Center of Excellence.
Thank you, Cobus, and good morning, everybody. Just in case anybody's unfamiliar, GlaxoSmithKline is a global science-based healthcare company. We are active in just over 150 countries across the globe, and we research, develop, manufacture, and market and sell products in the pharmaceutical, vaccines, and consumer healthcare space. I think it's important that we all understand the scale of the issue with regards to corruption across the healthcare sector. By no means do I have the prowess of the OECD in economic analysis, but some basic facts and figures I think are always helpful. The World Economic Forum has given an estimate that 5% of global GDP is lost to corruption each year. That equates to $2.6 trillion each year. Now, very crudely, the healthcare sector equates to about 10% of GDP. So the opportunity at hand here is $260 billion a year. So I ask you to think of the hospitals that are not built, the doctors that are not recruited, the patients that don't receive the treatments they deserve, the research that is not undertaken, and the fact that medicine that helps people do more, feel better, and live longer is foregone. If you find this unacceptable, please raise your hand. Okay. So let me think about the vulnerabilities from an industry perspective, because it is fair to say there are challenges across this sector, and the industry is absolutely one. But before I do want to raise a moment of praise for Transparency International. The work which they've published today on the typology shines a light on the practices across the sector. It does cover industry, but also more broadly across the healthcare sector space. And without understanding and appreciating the circumstances where corruption arises, there is no opportunity for us to take a targeted and focused effort across the sector to address the challenges which it faces, to ensure that hospitals do get built, that doctors are recruited, that patients do receive the treatments they deserve, that research that should be undertaken is undertaken, and to ensure that people are able to receive the medicine that allows them to do more, to feel better, and to live longer. So let's recognise that across industry we have a number of touch points and interfaces where we may come across instances where there are requests, opportunities, and in some lenses, in some circumstances, some would say incentives for misconduct through bribery in order to create competitive advantage. This comes across in instances regarding access to markets of our products. Simple things like clearing items through customs. It comes through instances such as the approval of medicines, various and varied regulation across the globe in different countries and different territories requires careful navigation and many touch points with those who could and sometimes are alleged to request bribe payments in order to facilitate the work which they should do as a matter of public duty. Also, instances where there are opportunities to inappropriately influence the price or the volume of products that are sold. So I want to talk to you about a couple of things that we've done at GlaxoSmithKline, things that are leading the industry with regard to changing our practices. Because as we've examined what we do, we have come to realise that some of the things the industry previously regarded as ordinary practice no longer are. And it is no different to the concept of smoking a cigarette on an aeroplane. A generation prior to our own, this was acceptable practice. It is no longer the case, and no one would accept it today. So, two particular things I want to raise attention to. Paying healthcare professionals to promote our products on our behalf. We have stopped this practice. Instead, we now use internal experts, and if a healthcare professional wishes to speak without payment and ensuring that we have cleared strict requirements for conflicts of interest with that healthcare professional, that is the way we do this. The perception of the conflict of interest, where a drug company pays a healthcare professional to promote their product, is no longer acceptable to us. Incentivisation of sales forces. At GSK, we no longer incentivise our frontline and first-line sales force on the volume of drugs sold. Instead, their bonuses are made up based upon their product knowledge and the quality of interactions with healthcare professionals. This is a market-leading practice, and where we are going, we are starting to see, and we are encouraged to see, others following. And I think it's worth recognising that as a multinational business, we do, and we have an obligation and we feel a duty to make access to our products across the globe. But the fact is this: there are a number of jurisdictions across the world where being able to conduct business in line with the governance standards we require and society expects of us are more challenging than others. Regrettably, this does have a bearing upon decisions industry makes, because we have a zero tolerance to bribery and corruption. We will not accept it, and we have to make decisions based upon the risk which we face. I therefore think it's worth asking whether governments and professional bodies, whether they are doing enough in the challenge against corruption in the healthcare sector. The expectations on compliance programmes at healthcare and life science companies have never been higher. We've taken the strides to re-examine the practices of our industry, and we are prepared to make the changes necessary. But are those responsible for the administration and delivery of healthcare in the public sector equally focused? And I bring us back to the opportunity at hand here. For those of you that raised your hands, you found this unacceptable. Even 1% of that $260 billion per year can make a difference. Would build a hospital, would recruit a doctor. And so therefore, I ask you to bear in mind that opportunity as you go through your work here at the World Health Summit. I encourage you to look at Transparency International's work on the website that Sophie showed you earlier. This has shone a light on areas where we need to understand circumstances of corruption arise. Industry faces its challenges, and we at GSK are taking a leading stance in the industry. But I do request that across the sector, others who have influence do examine the practices. so that together and overall we can have a global healthcare system that is reduced in its influence, malinfluence of corruption, and better for the patients which we serve. Thank you.
Thank you, Andrew. You raise a number of big issues, and clearly how to deal with conflict of interest remains a big challenge in terms of promotion, and we are very far from agreed industry standards how to deal with this. Similarly, the issue that you raised in terms of incentives not being based on volumes of sales is something that is a challenge that is counter to how this works in many other sectors. And this is where, when you have issues that are so directly related to public goods, such what health is, it is often a difficult one. So we don't have good examples from other sectors in this, and that indeed makes it difficult. And lastly, the very important point that you raise, that this has to be tackled sector-wide, and for that reason, not only all of the big players, but governments, big companies together, because this is issues that no single player can make a sustainable impact on. Thank you for that. Our next speaker, Dr. Susanna Hill from the World Health Organization, where she's the director of the Essential Medicines and Health Product Department. She's a clinical pharmacologist and has a long and very in-depth knowledge in this area. Susanna, thank you for joining us.
Good morning, and thank you all for getting up on a rainy Sunday morning in Berlin. I want to talk a little bit about the other side of this question, which is good governance and where it can contribute to where we might want to be in 2030. As you know, we have the Sustainable Development Goals as our overriding agenda, if you like, and Target 3B requires us to have access to safe, effective, quality and affordable essential medicines and vaccines for all. And Target 16 talks about promoting the rule of law, substantially reducing corruption and bribery, developing effective, accountable and transparent institutions, and so on. So if we are to reach this Access 2030 goal for all, I think it's important to start with where we are, and I want to tell you two brief stories to illustrate some of the problems that we're trying to deal with at WHO. One is a short one, and it goes back a few years. In December 2012, Pakistan reported 50 paediatric or children's deaths in relation, it seemed to be, to ingestion of a particular product. The office there and the country investigated the cause of death and found that it was due to contamination of a product with a toxic substance instead of the normal component that was part of the API required for this particular product. WHO, through its Global Alert and Reporting System for Substandard, Spurious, Falsified, Falsely Labelled and Counterfeit, and that's SSFFC if you say it slowly, products, reported that as a global international alert. And in Pakistan, we supported the Ministry of Health and the investigating group to try and manage removal of the product from the market. That's very challenging in that particular context. Where it becomes even more problematic is that in September 2013, so nearly 12 months later, Paraguay had 46 patients hospitalised related to ingestion of the same product. However, they were actually a little luckier because they were able to get on top of the problem sooner than Pakistan and were able to support most of the patients, so there were fewer deaths. But then Colombia and Peru also started trying to trace the API because they got word of the problem as well. So my point here in this context is that if we look at the quality of products that we would have to try and manage to get to Access 2030, we're going to have to deal with it globally. Let's move forward to this year and another story. And this is based on reports that have been published in the press in Indonesia. There were increasing number of complaints about problems with vaccination of children. So this is the primary vaccination course that we rely on to manage basic childhood mortality and reduce childhood deaths. And it started to appear in the press and a number of arrests were made. And then the story started to unfold. The primary vaccine, so a triple vaccination containing diphtheria, pertussis, tetanus, and then Haemophilus influenzae components, was found to be falsified. It was a very complex web that is still being unravelled, but to date what has become clear is that it was all the way through the health sector, not just the pharmaceutical and health product sector, involving, for example, collection of vials of real product that had been used, washing them, refilling them, relabelling them with a product that sometimes contained some vaccine, sometimes, if you were lucky, sterile saline, and sometimes just water. Sometimes a little bit of local anaesthetic to reduce the risk of pain. So what was happening was that prescribers in the system were saying to patients, you can have the locally provided vaccine, it has a few more side effects, it causes your child to have a bit of a fever, or you can have this imported one which has fewer side effects and I'll give you a good price on this. And the whole system was constructed around this linkage of payments, kickbacks, leading to problems with vaccination, problems with falsified products and problems with healthcare. Now, we're still trying to understand the drivers in that whole scenario, but to date, the President of Indonesia has replaced the head of the Drug Regulatory Authority as a starting point. So we see again that this is a system-wide issue that has destroyed confidence in the primary vaccination program, and we're now starting to look at what impact it may have had on the public health. So if we look across the health product sector then, we have several symbols or symptoms, if you like, of problems. We have problems with access that lead to out-of-pocket payments. We know we have a problem with prevalence of substandard products. For example, we see about 30% of the antimalarials, we think, in Africa may be substandard, etc., SSFFC products. And we think this reporting is just the tip of the iceberg. The reasons why, I think, are very simple, and the previous speakers have in some ways covered them. First of all, health products are big business. There is a reluctance to control the markets to the extent that is probably required in some settings to actually manage this appropriately. And then there's also the question of capacity to do so. So, from WHO's perspective, we see that there are two trajectories of work for us going forward with countries and with collaborators and stakeholders that will get us to Access 2030. Firstly, we are committed to support the development of good governance across the health system. We want to work to ensure that there are strong institutions that, with respect to products, are capable of preventing substandard, spurious, falsified, falsely labelled and counterfeit products on the market, that can detect them when they're there and can respond, as we saw in Latin America with Colombia and Peru, appropriately to minimise the risk of public health harm that results from these products in the market. We have worked on, in the past, assessment and are continuing to work on assessment of standards for institutions. What is the standard that a regulatory authority needs to get to ensure control of the health product market appropriately? We need to measure impact of the products that are out there and the problems with products. So we've set up a reporting system for SSFFC products, but we also see a need to work on reporting systems for safety. We see that we need to support the development of an accountability culture and a transparency culture as well. And in the work that's been done in the past on the Good Governance for Medicines programs, which is a multi-stakeholder approach, the focus has been on ensuring that institutions become accountable, responsive and transparent to their community. And finally, I think if we are to reach Access 2030, it does require all of us to join up with this. It's not sufficient to say it is a problem of governments, it is a problem of industry, it's a problem of the community. It does require building a multi-stakeholder approach to get us to where we want to be, which is access to medicines and vaccines for all. Thank you very much.
Thank you very much, Susanna. Two things to highlight, your call for the multi-stakeholder approach and outlining how indeed important it is that we can often have rapid global action that's well coordinated. And surely I think that in the last 2 years or so we've seen progress in that field, and that is one that I'm cautiously optimistic about. The other issue that you raised that I think is one that I'm much less optimistic about progress is the particular vulnerability of people or their children in need of health care, and how that exacerbates opportunities at the point of delivery where somebody is willing to pay or to take other products because they are desperate for that care. And that is something which, again, where the healthcare system is unique, because it has such a direct vulnerability at that point of delivery. And I think that is one where a very different transparency and accountability model indeed has a lot of work still ahead of us. Our last panelist is an old friend of mine, Tewodros Melessa, who is the Director General of the International Planned Parenthood Federation. The floor is yours.
Thank you. Good morning. It's really a great pleasure to be here among you. And I think as I speak about the issue of corruption in the health sector, and especially when it comes to sexual and reproductive health, there are two things which come here. The obvious one, which have been already described, but when it comes to sexual reproductive health, it becomes too personal. Things which cannot necessarily come out very much into the public, into either the documentation or putting that forward, because there are morality and subjectivity which are associated. And for that, that's what I would like to say is what's important is the ownership at the local, at the community level of any commitments or any things which are happening is very critical. That's why I want to differentiate in the presentation is what is that social accountability, and then what are the ways of some of the examples of how we can ensure that accountability, and then the issues of corruption in a very concrete way, then what are the challenges which we are facing. Oh, now technology. Okay. All right. What is before the social accountability issue is that I think any commitment, the transparency should start from what are the objectives, what are the plan, what is the commitment of a government, be it at international, at a local, at a community level. If it is not clearly stated, what are the budgets, what are the objectives, what are the plan, the implementation strategies, then forget it. Because if you don't know where you are going, you'll never get lost. If people have not told us what they are intending to do, how can we hold them accountable? So, the different areas of the interventions that we are going to be putting, how at the local level the community should have a way of monitoring and collecting information. Now, the global community is committed to the SDGs. But what does even SDG mean in local languages at a community level? What are the implications? What are the responsibilities? That's what is really important. For us, the lower level, at the community level, should know what their government has committed. What is the budget going to that community? What are the challenges that the community is facing? If that is not clearly set, and they are not informed clearly, they cannot monitor, because they will make it in the abstract and say, okay, we have built bridges and so on, but when the healthcare services are not provided due to many factors, they cannot be holding accountable. If they know, I'll give you some example, for example, what we did in Uganda, our association, is that at the community level, they participated with the local government in setting the objectives, the budget allocated, and what the clinic is going to be getting. And that helped to do the social audits with community leaders and with the providers. When they have that budget, they ask why is it, when they tell them there is a commodity shortage, say, where was the shortage due to? Is it because you don't have the money, or you got it at the high level and then you haven't delivered it at the local level? The citizen education, which in Uganda, for example, they have done on the budgetary and interface meetings of duty bearers, about 60 million shillings, Ugandan shillings, were allocated. And that means in the Busia district of Uganda, 100 more safe and assisted births took place because that budget was allocated and the community were able to control how that was moving. And that ensured that the local authority has to get the commitment of the federal, the national government in making sure that the communities and the healthcare providers. Sometimes what's happening is that the healthcare providers are not paid their salary. When their salary is not paid for 2, 3, 4, 5 months, then what do? They charge the people who are coming. It's corruption, but their problem is also challenged due to the inefficiency of the administration. If we don't fix that, if the government doesn't fix that inefficiency of the administration, then they have a very serious challenge. The other is, if you train the community health worker, which in one community, in rural health mission in India, female health workers were trained. They interact with the formal health sector, which is the hospital, and which is the district, the Ministry of Health, so that the needs of the community are also addressed. If it's not addressed, then that female health worker and educator, like a representative, addresses that to those who are elected at the district level. And that text also can go to the press, to the national level. That's a way of engaging the communities, which is really important. Now, just to give you a few examples of these corruptions, one, as we say, by omission, instance of negligence which compromise service delivery. The staff, in some places, there are staff, they are dead, they are retired, but they are still being paid, but they are not there. And who is doing that? At any level of the Ministry of Health, some of them are taking the payment, but the community is suffering. Supply issues. They select. They don't buy necessarily, what is required for the community. In the issue of contraceptives, for example, it's easier not to buy contraceptives and then to go to the curatives, because the curatives, they generate more money. The preventive, the consequences at a later stage. So then training, unqualified staff. They never admit that they are not qualified. I remember in one clinic I go, and then I said, "Are you providing IUD services?" They said, "Yes, etc." But what I found out is that since the nurse was not trained in IUD insertion, rather than admitting that there is no training, the best thing to say is, "No, we don't have it. It's not good for you." And then what happens, through a certain form of funny arrangement, she is referred to a physician who's working in private. So you go and pay more, but whereas at that service level, it's not there. Omission. It's a deliberate holding, giving, asking for fees. The monitoring, unethical procurement practices. When there are drugs which are not approved by WHO or by the local authorities, they are smuggled. That smuggling profits the individual traders, and it puts the health of the women and young men and young people at risk, especially when it comes like, HIV/AIDS treatment, STIs, for abortion, all these unethical practices of the health sector. Now, when I come to sexual and reproductive health, I'll give you a number of examples which are really tragic. In one country, we have a project to provide safe within the legal framework of abortion. What happens? The doctors, they lobby the government so that abortion is provided only under certain conditions. This has nothing to do with medical ethics or moral ethics. It is to ensure that those who are qualified, the doctors, are going to be paid more because the client is going to be spending more time. So the price increases. The injustice is coming at that level. Some of them, they even want it to be clearly stipulated that they cannot be provided for no professional or ethical reason or moral reason, just purely as corruption to enrich themselves. Some, the prescriptions even for the most banal, contraceptive pills, in some of the cases, even condoms for young people because of age, has to be testified by a doctor that there is a consent of the husband. And that means consultation fees. That means higher doctor level, whereas it could have been provided by a community or the drug seller. Whereas more dangerous drugs are sold just around the counter for the contraceptive services, there is a restriction. These are some of the challenges which is faced. The other, I think, which the international community and the transparency should be looking at, is the indirect corruption, lack of transparency. If you have any administrative cases or legal cases, the ones which are going to be defending you, to be protecting you, they charge you more than what you would be losing. Or, in some of the international development assistance, the whole thing, when you take the overseas development assistance, it costs more than if the private sector provides, if the money is given directly to the client. Where is the ethics? Where is the transparency? If to provide one cycle of pills is costing $100 or $200, whereas a cycle of pills, the most expensive, costs maybe $5, where is the ethics? It's not a clear and a direct corruption, but it is an indirect corruption of the public trust. And corruption is not just a material. There is ethical, there is that cultural thing which you lose trust in the public sector, which you lose in the commitment of the local, the international intent. And believe it or not, when there is that lack of trust, it can even lead to violence, social unrest. So it's not just a moral issue, it's not just a legal, but it is an issue of a sustainable development so that people can have a trust and faith in their society. If we don't tackle that complex issue of corruption and bring in the transparency. For us, we work in over 170 countries and we say we are locally owned and globally connected. The locally owned is also translating what SDG is in the local and community individual languages. Because if it's not owned, it becomes the bureaucratic language at the higher level, and nobody knows for what we have committed, and we'll never get lost because we don't know where we are going. Thank you.
Thank you very much, especially also for not only pointing out some of the challenges, but also adding the element of new opportunities in the issues of social accountability, social control, and particularly how the currently exponential increases in ability of ICTs enable people to participate much more directly into giving feedback, giving and participating in the quality of services that they are provided. Surely from where I'm sitting, the nature of social activism is changing so dramatically, and we are seeing in pockets of the world where we have very repressive regimes that ICTs still enable people to participate much more actively, and surely where this is starting to happen in service delivery areas, we will, over the coming years, see quite dramatic changes. Thank you very much to the panel. They have made my job very easy. We are even 3 minutes ahead of schedule, which is fantastic. In classic African style, I'm South African. We always pride ourselves when we are ahead of the clock. What I would now invite everybody that is present, well, if everybody does it, we'll be here for too long, but for some of the audience, if you have any questions, I would ask you to be very brief. If you can just say your name and the question. I would also encourage the panel, given the very interesting mix of panelists that we have, that if you want to respond to things that your fellow panelists said, please take that opportunity. The plan was that we take a round of questions and then give the panel the opportunity to respond. I will take that to see how the time goes, whether we have a second round. So could I see from the floor those interested in asking a question? There are 2 mics set up. And could I also, because I'll take a few questions, can you think during this so that you'll have the opportunity immediately after this question? Yes.
Hello, everybody. My name is Tim van Els. I'm a medical student from Leiden, the Netherlands. I have a question for Ms. Hill. First of all, thank you very much for your interesting talk. So you suggested to address corruption, that one of the ways would be to have stronger institutions. But sometimes the huge power of institutions is exactly the problem of corruption. So how would you prevent institutional corruption in those powerful institutions? Thank you.
Thank you. Other questions?
Good morning. My name is Rashid. I'm from MCI University, Austria. So first I have a comment. Thank you very much for all the information. What is clear that corruption and health, it's now complex and involving a lot of stakeholders. And I think it's also unbalanced impact of corruption in some countries where there is more transparency and accountability. It's clear they are proposing some regulation. But the problem for some, like Africa or Asia, where government or countries are still facing some problems to implement accountability and transparency. So I think it's time to make a call for international regulation. My question is open. I think, what do you think that about calling for a treaty or convention, international convention or treaty regulating this, so at least we can have a fair protection against corruption over the world? Thank you very much.
Thank you very much.
Hello, thank you very much. My name is Julius Murke. I'm a member of the organization Young Leaders Fair House. Dr. Hill, one question to you. How do you see the role of information technology, maybe smartphones, in proving falsified drugs for patients? And maybe one question to the whole of the panel in regards to what Mr. Melez said of owning and social accountability. What role does open information play in regards to corruption?
Thank you.
Hi. My name is Valentina Yammi from the London School of Economics. My question is around social accountability and civil societies. What is the role and the impact that they can have in the battle against corruption, generally for drugs, but also for practices? So in something more tangible, so in something less tangible, like mental health, for example, where drugs are often not the key ingredient on the and the key intervention. Thank you.
Thank you. Maybe one more question and then I'll come to the panel, and I won't have a sequence. I'll give the panel the opportunity who's ready to respond to go first. So there's two more. So let's take those two at the back, yes?
Yeah, thank you very much. My name is Adere Mikuku. I'm the president of African Academy of Science. Actually, the issue of corruption is a very disturbing phenomenon all over the world, especially in the developing countries, especially in the African countries. And it affects not just the health sector, but everywhere. And it's particularly depressing in the health sector when you find that even many countries that can afford to do things for their people still indulge in all these excesses. But the point I want to make is that a lot of these excesses are also being promoted by the international community, because a lot of the funding come from abroad, and people who execute these funds collaborate with local people to do all sorts of things. As a result of which the healthcare don't get to those who need it. What can we do as an international community to stop these excesses? Thank you.
Thank you.
Thank you. Shima Biswas, General Surgeon, Red Cross, and BMJ Case Reports. My question is there any evidence, especially in emerging economies, that increasing doctors or medical salaries in general reduces corruption in the health sector?
Thank you. Thank you very much. So we've got essentially about 5 groups of questions. One around stronger institutions, then about, secondly, the role of information technology, open data, social accountability. Thirdly, around the issue of international treaty, but also the role of the international community, how that relates. And then fourthly, the issue of the evidence question in terms of medical personnel. So who of the panel would like to start? Susanne?
Thank you very much, and thank you for some interesting questions. The question about what happens if you have an institution that gets too strong, I think is a really interesting one. And I think Norman Daniels' framework, accountability for reasonableness, is our best option for trying to manage that, so that what we expect is that institutions have firstly appropriate legislative or administrative frameworks that govern their activities, that they have decision-making criteria, if that's what they do, that are seen to be reasonable by all their stakeholders, that they have a system in place or a mechanism in place for appealing those decisions, and that finally that those decisions are actually reported and reviewed. While that may not be a perfect recipe, it's certainly at least a good structure to start with, and I think it would be interesting to look for examples of institutions that comply with that kind of approach that are seen in some way as too strong. The other question that I wanted to respond to was the role of the 21st century technologies in managing quality of product and so forth through IT, smartphones and whatever. Clearly this is a huge opportunity, and I'm aware of at least several systems that are already in place that are being offered in different countries, where you can either scan a barcode and see if it's a barcode that's registered with a company. You can actually look at the batch number on a vaccine and see if it's a genuine one. We're piloting an app, as WHO, we're piloting an app in a couple of countries at the moment to see if it can help with reporting on suspect products. We've also done a little study looking at the use of an app for measuring availability of products on the shelf in facilities as well as their price. I think it's the way of the future, but there's no point in having data if you don't have the capacity to use it. So from my perspective, while data is the first part, the second part, and integrally related, is analytic capacity in institutions to look at the data, assess it, and come up with appropriate policy responses.
Very interesting and challenging questions, I believe, and especially, about information, getting the right communication and that transparency at all levels is really critical. And this information cannot come if there is not a full democracy. If there is no democracy, you cannot get information. But the biggest challenge now we are facing is that in the developed world, people are losing faith in the old establishment of the institutions, the monopoly of the media. There is that transparency is diluted by the concentration of the media power into few selected rich people. And then the emerging democracies in the developing world cannot be in that international agreements and so on to respect. Now, here comes the role of the IT and the parallel information system, where it has to give the information to the public. What are those conventions? Multiplying conventions is not going to solve the problem. It makes it more complex. But what are those things? What are things which are going at the local level, at the nation level, at the company level, at individual level? That information is very critical if it reaches the community so that they can challenge their elected or halfly elected leaders. Thank you.
So I want to say I have good news for the gentleman who came with a question from Austria, because there's actually a convention that has recently come into force in January 2016. There's an international convention which was drafted by the Council of Europe, and it's called the Medicrime Convention. And this is specifically on counterfeit and substandard medicine. Now, a convention only exists if countries actually, pledge to join. So there's a number of people who have signed and not yet ratified, ratified being that it's been put, by Parliament. But there is now a new convention that is specifically targeting counterfeit of medicine and providing tools for international corporations. The countries that that signed the convention agree to criminalize the counterfeiting of medical products, etc. So I think this is a very important, positive development. I also wanted to talk about open information, which was one of the questions that was asked. So I take this the OECD hat and not the developing, or more developing economies hat. But open information and transparency is being increasingly supported by regulation. I don't know if you've heard about what are called the Sunshine Acts. But these are basically regulations, and the first one was done in the context of the Affordable Care Act of the United States, where essentially there is an obligation for providers and pharmaceutical companies to provide information about the payments that are done and any financial ties that are between them. So if a doctor is receiving money for promoting some products, you will find all the information in a database about the amounts, etc. Now, a number of countries have put in place such regulations. France, I think there are five or six. Very interestingly, as of January 2016, the European Pharmaceutical Industry Association, and I'm afraid I don't remember their acronym exactly, but so it's the professional organization that the umbrella organization for pharmaceutical industries working in Europe has actually also put to their members that they should disclose whatever payments they're doing to providers. So there is a lot, and in a way, this is much more advanced than even what some countries in Europe do. So I think this is interesting to see that it comes from the industry. Now, the thing is that once you have the information, what happens then? Because people need to be able to use it. It needs to be accessible. It needs to be researchable in a user-friendly way. And this is not always the case, but at least some progress is being made in that direction. And the other aspect is, the other trend is around clinical trials. So there's a lot of regulation that says that clinical trials should be registered, but there's internationally more and more call for the clinical trials data to be actually released so that people can analyze it and take a second look, and other researchers can look at the results. So I think these are two elements where you can see that there is a call and emerging progress on having more information open to the public.
So again, I would like to say some excellent questions, and I'd like to just expand on some of the aspects around IT and use of IT in the fight against corruption. Because the reality is this: those of us that are baby boomers, Generation X's like myself, we're being replaced by the millennials. And the reality is that the ways in which interactions are undertaken between industry and healthcare professionals are evolving. So I'd just like to give a bit of... Oh, am I on? Oh, does this work now? Yes, can you hear me? Thank you. Does this work now? Yes? Okay. So, thank you. I want to just pick up on the matter about IT, because the reality is this. There are those of us that are baby boomers, those that are Generation X's, we're being replaced by the millennials. And so the interactions between the healthcare industry and healthcare professionals is going to evolve. I'd like to just give a bit of a window in some of the things we're doing at GlaxoSmithKline. So we've introduced a multi-channel approach to our interactions with doctors for the purpose of detailing our products. No longer do we rely solely on face-to-face interactions, And so we now have a range of different methods through use of webinars, click-to-chat methods and portals to help increase awareness and understanding of when our products are the appropriate product for the treatment of a patient. You may say, well, what's that got to do with corruption? But the key thing it does is that it reduces the number of face-to-face interactions and therefore the number of instances where a sales representative could be put under pressure to pay a bribe, or indeed, I'll be frank, a sales representative could see an opportunity to pay a bribe is reduced because that face-to-face interaction has gone. I'd also like to raise awareness of something else we're doing at GlaxoSmithKline. We are commissioning a piece of work with the Basel Institute, and the piece of work we're commissioning with the Basel Institute is asking them to start, we won't be able to do it all, but we'll do a start of a global register of electronic platforms that can be used as an alternative to face-to-face interactions when dealing with government officials. This will be instances such as paying licence fees, registration fees for products and so forth. Currently, there is a huge veracity of regulation, a number of instances where we have to interact to obtain licences and permits and so forth. That's fine, we understand that. But actually, if we can just work out where the opportunities lie in order, across the globe, in order to reduce those interactions, that makes it a safer environment from an anti-corruption perspective. So this piece of work is starting, and when it's available, we'll make it publicly available for all to have the benefit of.
Sorry, I'm dealing with a minor health emergency here. Thank you very much for the questions. They're very challenging, very interesting. I thought I'd come back to the question around the international convention. I just wanted to add to what the other panelists had said, that you might be also aware that there's a push right now to have a global convention on public health, which is being led by Professor Friedman at Georgetown University. The issues of governance are actually at the core of this convention. So I think this is another way that the issues of governance, transparency, and the anti-corruption movement are being brought together with the public health community. So I would keep track of what's happening there. I think it's a very interesting development. I'd also like just to add to the ICT issue. Within Transparency International, so we're a global anti-corruption NGO with almost 100 chapters across the world. And we've been in touch with quite a few of them, especially in Latin America and in Africa, who are indeed looking at ICT as a way of looking at the whole spectrum of issues that come up under the corruption lens. So it can be from tracking the allocation of health spending, which Teodoro mentioned this morning, which is absolutely key. How do you bring the SDGs down to the local level? To if you want to have a look at what's been done in India, I Paid a Bribe. It's an amazing app. It's really put the issue on the agenda. The British Medical Journal has done an amazing campaign around that. So just coming back to what is being done on ICT, I think there's a lot there. It's helping to put information into the hands of the community. Granted, I think the challenge is the information usable? Is it desegregated? Can we use it in order to develop some policy recommendations and advocacy on that? That's going to be really key. And I think that's one of the main issues I wanted to address. So thank you very much.
Thank you very much. I have the unenvious task that we have a little bit of time, but not sufficient time for another round of questions. I think that two of the questions were maybe not so directly answered because they were also quite specific in terms of the evidence of doctors, and I would suggest maybe, Sophie, if you can pick that up and we can follow that. And I think the accountability and drugs issue as well, that one explores those a little bit more. So before I bring this to a close, I would give, if there are anybody on the panel that would like to make a final comment, the opportunity to do so.
I think, just to say that, especially in the question relating to the emergency situation, I think the world, unfortunately, is living in so many emergency situations today. it's very critical that there is transparency on how essential medicine and the health of those who are displaced or in conflict situation or in disastrous situation is really looked as a matter of priority. Thank you.
Thank you very much. From my side, 3 final comments. Firstly, thank you very much to everybody for coming. I think that not only were the questions excellent, but also in terms of from where I'm sitting, the active participation of the audience during the presentations, very much appreciated. To the panelists, thank you very, very much. From sitting as a chair and seeing the variety and the mix that we had, I think it's indeed a very interesting panel that's been put together. And yet there was a common drive in terms of our quest to move the issue of transparency into a new dimension, both in terms of how we do better care, how do we do better participation of those that are recipients of healthcare, but also how do we enable the healthcare professionals to actually do what they set out to do, because one should never forget that people, by and large, that enter into the healthcare profession does so because they actually want to make a real difference. They want to save lives. They want to actually give people a better quality of life. It's a profession that, by its very nature, starts with a position of making things better for people. And I think that even if we would sometimes have battles between whether the healthcare profession and what is demanded from it is always mixed, one should never let that out. That I have in my life not come across a doctor who's not dedicated to provide care for patients. And I think that is a fantastic point of departure for us. Secondly, as an African, I cannot help but telling a story. I'm not a healthcare professionalist, so I'm an activist. But one of the more inspiring presentations I saw in the last couple of months was in New York at the Global Compact, where you had big companies coming to say what they would do and what they can do to make a difference in terms of the Sustainable Development Goals. And there was a CEO of a big telecommunications company, and he, in a very powerful way, showed what happened in South Korea during bird flu and what his telecommunications company could provide in information that was really extremely useful in terms of dealing with the spread of the disease as well as preventative. And whilst he was very clear that open data, that sharing of all of that has its own challenges, he made the statement saying that probably less than 100 companies in the world, if they were to agree to share that information that they have publicly, it would probably make, as it could in that one case in South Korea, could make such a dramatic impact on our control and treatment of diseases. And he said he committed himself that his company is willing to do that, and urged the UN and the Secretary General, who is now the past Secretary General nearly, said that he was committed to look into that. But what was powerful to me was you don't really think you would get a telecommunications CEO getting up on the stage and inspiring you in terms of what can be done in terms of healthcare. And that, I think, is where us thinking out of the box of new solutions, it often will come arguably from also us not only working within the sector, but also with those outside of the sector. Lastly, the only part of self-promotion, I think the report that Sophie and the team has put together is excellent, and I would urge you to have a look at that and interact with that, because I think it does make a contribution. Thank you very much for coming, and wishing you all of the best for the rest of the day. Let's give the panel and ourselves a big hand.